Welcome to the special episode, What Primary Care and Emergency Medicine Providers Need to Know About EoE in Children. We're joined today by our special guest, Dr. Sophia Patel, who is a pediatric gastroenterologist at the Cleveland Clinic, where she's also medical co-director of the Pediatric Eosinophilic Gastrointestinal Disorder Center. We are so glad and so happy that she's here with us today. Welcome again, Dr. Patel. Nice to see you.
Thank you so much for having me again.
So we're really talking about a very important topic, all aimed at education for the non-GI provider and ER physicians who may see children and teenagers in the ER or in their office who may have symptoms of EoE and they may not know what they are. So we're going to walk through some of the clinical presentation of what that may look like, as well as questions they can ask their patients to get to the indication that this possibly could be EoE and to refer to a gastroenterologist sooner. So I'm so excited to have you here, and we're going to talk about this. So what are the first things that our pediatric providers and non-GI healthcare providers in the ER should know about this condition?
Well, I think the most important thing is it is missed a lot in the ER, and it can also be missed in just the pediatrician's office. Many kids present with similar symptoms. A lot of times you don't ask the questions specifically about trouble swallowing. And when patients get older, they are able to kind of tell you their symptoms a little bit more. Younger patients typically come in on a different sort of spectrum of clinical presentations versus older patients. Our patients that we see that are under the age of 5 typically will have not the most classic symptoms of difficulty swallowing or food getting stuck. A lot of times they're picky eaters who don't improve with time. They have emesis or vomiting. They will complain of abdominal pain, and then they will also have slow growth. So all of those things are something that a pediatrician could certainly look out for. Concerns that the parents might bring them that their kid, doesn't like to eat very much. They're very picky. They've been not gaining weight as well as they've hoped, or their growth chart is kind of not doing so well lately. Maybe they've lost more weight, they've become more picky. A lot of these patients also will have, more of a kind of a picture of acid reflux, where they will eat something and within an hour or two, they'll throw up. Their throw up might be the food. It may be just like, saliva or stomach contents. And oftentimes they will just be started on an acid medication, which is completely reasonable. We don't like to scope everybody who comes in with vomiting, but if they have other red flag symptoms, like if they're losing weight or if they're not eating as much or they're refusing foods, they're, holding on to foods in their mouth, they're taking a long time to eat, not just because a lot of kids are very distractible eaters or they're, watching TV or playing when they're eating, but when they're eating, if it's taking a very long time, if they're chewing and hanging on to food in their mouth, those kind of things are definitely red flags to think about sending. And a lot of times pediatricians will send to speech therapy, or they'll send to, occupational therapy or feeding clinics. And that is often, that's a big referral location for GI in general. So if they come in from that way too, that's great. But that typically, if you're seeing some of that, it is good to have an evaluation for other causes like EoE in that patient population.
So let's break it down. We'll separate the scenario. So I guess the first case would be in the ER. Typically, if a pediatric patient or a teenager present in the ER, what would they be presenting for that an ER doctor should be looking out for to possibly make the referral to a gastroenterologist?
That's a great question. So part of what we see from the ER primarily are going to be your older population of patients. So the 14, 15, 16-year-olds, they were, out somewhere or they were up late at night without their parents awake, and they were eating, a leftover cheesesteak from the fridge, and they ate it and it got stuck. And this is probably not the first time this has happened. Most kids will have like a series of events where it happened once and it was okay, it went down, like no big deal. And then as time goes on, these impactions become a little bit longer, they last a little bit more, you're having trouble swallowing your spit. And it comes to the time where, you're waiting and you're trying to get this. A lot of kids will kind of run to the bathroom, try to get it spit out by sort of making themselves retch. And then they come to a point where it's not moving. And that's when the patients will often present to the ER because it's been stuck there. And often it's already been stuck there for a while. Most of those patients that come to the ER, they've tried several things at home, probably to even try to get it to go down. Most parents are like, okay, well, let's try some Coke, or, you can't get this popsicle. And it ends up being like a longer period of time that's already been there when they come to the ER. So that's something to kind of keep an eye out for as well. And then when they come to the ER, the patients that we'll typically see are with the food impactions are the ones that are having difficulty swallowing their saliva. More severe presentations are they'll have very harsh chest pain. They complain of it a lot. They're not able to handle any of their secretions. So when they're making saliva in their mouth, they have to spit it out into a bucket.
Oh, wow.
Those kind of things are definitely more red flags to where they need to get that food impaction removed sooner. Those patients are typically the ones that we see in the ER.
And for those patients, for the doctors who may see them, they remove the food impaction. And what typically happens? So like, this is where there's an important point that we want to make here, which is what, Dr. Patel?
Right. So the big thing is these patients with food impactions often have an underlying eosinophilia in their esophagus that's leading to the food impaction. Other cases could include, if you've had esophageal surgery, you've tracheoesophageal fistula disease, or achalasia, which is not as common in pediatrics. Eosinophilic esophagitis is one of the more common causes of food impactions, and those kind of things are we see them often as the first presenting sign is they come to the ER because they had something stuck. A lot of times different hospitals will also refer to different GI providers or ENT to remove these food impactions, especially if they're up higher. So sometimes we don't get the diagnosis that we need because we need to have the tissue biopsy when those patients are getting their endoscope or they're getting a scope from ENT. And that often can lead to delay in care because they don't get referred back to GI because they didn't get the biopsy, but it's a very classic common presentation of EoE. And it's helpful to also when, you're signing out to that provider that, you should look for EoE and maybe we could do some extra biopsies, and they definitely need to follow up with GI after the ER visit. So that's something else that the ER can help coordinate, is just to make sure that they have a follow-up visit with the gastroenterologist after that food impaction. And that can definitely help guide some of the care as well.
That's a great point, because what we don't want to happen is they get the food impaction out, the referral, even if it was a gastroenterologist that did it, there's still, you want to have that continuum of follow-up, of care, so that they can get the diagnosis. That's an excellent point, because the opportunity is there, but we want to have the whole follow through.
Absolutely.
That's a great point, Dr. Patel. Now, just before we leave the ER scenario, are there any other presentations that either a pediatric or an infant would present in the ER that could lead to what you would want a referral to a gastroenterologist? Is there anything else?
Yes. So a lot of times when infants, we don't typically have emergent situations for infants with eosinophilic esophagitis, but if you're concerned, things to look for would be, severe emesis, anything that lasts longer than, 48 hours, I would say, if they're having significant vomiting, at least happening like every few hours. And obviously patients who are dehydrated or need IV fluids, not making wet diapers, not having bowel movements because of vomiting or because they're refusing foods. Typically, infants and toddlers will present more often like with our other findings, which are more like kind of more vague: abdominal pain, vomiting, weight loss, but kind of just a quick check at their growth chart would give you an idea of whether they need more closer follow-up with GI. And I know that's, you're seeing them one time in the ER, it's like one moment, but if you see that growth chart and it looks abnormal, then, and you feel like that's a good person to refer, then that's, certainly the patient that we want to be seeing too. So we want to keep an eye on that too.
Yeah. And this is a great example to maybe empower the physicians or the providers who are seeing them in the ER. Are there some important questions at this point that could be asked that could maybe trigger this may lead to I should refer to a GI?
Yeah.
There's some questions that they could ask.
Yeah, typically like what we ask would be in older kids, obviously, like how often have you been having food getting stuck? Do you feel like you're a slow eater? Do you often feel like it takes time for things other than even food to go down, like pills or things like that? And then things to ask patients of, younger kids basically are essentially like the vomiting. How often does it happen? Is this feeding issue, the vomiting, is it new? Is it been going on for a while? Is this acutely worsening? And then also asking about, whether or not the kids have been intolerant to other like more common things. Like, do you notice that they vomit after they have milk, or do they tend to refuse like one or two foods, or do they typically have more issues with, finishing their meals, and things like that are often triggers that you should think about referring to GI for.
Now let's go back to the office, like we're in, the non-ER scenario, dysphagia. What is that?
Yeah, so dysphagia is interesting because, again, it's kind of a spectrum, a continuum of different symptoms. And if you don't ask the right questions, a lot of times patients will not even tell you that this is something that they're experiencing. And often I'll be in the office and I'll ask a patient parent a question and say, do you feel like they ever complain to you about things getting stuck in their throat when they're swallowing? And the parent will say no, but then the kid will say yes. And they'll say, well, I didn't tell you because no one really asked me that. So the specific question would be, do you feel like when you eat food, sometimes it goes down kind of slow, or it feels like it gets stuck anywhere? And older kids can tell this. The younger kids often will not tell you unless you ask them directly. I also ask about acid reflux. So if they ever feel like anything sour is coming up into their throat or into their mouth, or after they eat food, does it feel like some of that food kind of comes up into your throat a little bit? Do you have any like burps that kind of feel a little bit yucky? And a lot of times kids will tell you when that's happening, especially the younger ones, because they don't know how to characterize it. But then they'll say, oh yeah, that does happen. And then often the parents are surprised because they're like, what? You never told me that. But it's, they're not really like, they're not trying to ask those questions actively. So, but that often is kind of a good way to kind of get them to open up and things like that. Things that the parents can help with is telling you, like, when they eat, do they finish later than the rest of the family members? Or if they're a teenager, like they're eating with their friends and they're the last one at the table and their friends are like, come on, man, hurry up. You're taking forever. And does that happen often? If it's more distractible eating, if it's not distractible eating. And then as kids get older, they become much more picky with certain foods. So if you see, the 12-year-old who's still eating chicken nuggets only, or hot dogs, or kind of more like crushed up pulverized meat rather than a piece of steak, or just like, a sandwich that's made of like actual chicken breast, that tells you that they've been kind of self-selecting certain things to eat over time. And they've picked things that are softer and easier to eat. And if you tell me your kid is eating like mashed potatoes, mac and cheese, and chicken tenders, and they're like 14, that's a typical like toddler diet for softer foods. I would say, like, as they get older, we're hoping that they can expand their horizons a little bit. But if they're still eating those things and that's the primary thing that they're eating, it's probably from them having had an experience where things got stuck, and then, moving on, it's kind of, they've avoided those foods. So
this is what the pediatrician or primary care family doctor could ask the parent and the child about. Now, how does this play out for the infants? Like, I know you said it was different, but what are some of the questions that a pediatrician could ask the parent about their child?
Absolutely. So infants are definitely more difficult to kind of figure out in many ways, because sometimes they do things just to do them, like to get attention occasionally. But most kids, like toddlers, are not, just vomiting for no reason. So a lot of times asking the parents, most often the best thing to kind of talk to them about is how meal times go. And if meal times are very difficult, everyone's fighting, no one's happy, we're refusing foods, we're not even trying new foods, then that could be an indicator that something is going on. And oftentimes the parents themselves will be the ones who bring them into the pediatrician and say, like, they throw up a lot, or, the kid eats and he complains of belly pain. Some kids are very, vocal about that kind of thing, or they're, just kind of like not in a great mood because they're not eating a lot of food and they're refusing other foods. And then that kind of makes them a little bit more grumpy. A lot of kids definitely are more picky and want to have snacks and things like that more often. But these kids are, often will not finish their meals, or they'll take a very long time to eat, or they'll throw up. And then that vomiting leads to them having more irritation in their throat. And then that also can lead to them not wanting to eat as much too. So.
Oh, wow. Now, how young can a child present with EoE symptoms?
So there have been case reports of very young patients, like infants to babies. You have to have the exposure to those typical allergens that cause those allergy cells to come up into your esophagus. So like most common things are like the top allergens are milk, wheat, eggs, fish, shellfish, nuts, soy, and in other countries like legumes are a big trigger as well. In some cases, there are more specific foods like lentils, pea protein, that kind of thing too. But typically you have to have the exposure to these foods to build up that allergy pathway. So you have to have the milk protein exposure before you can even develop that.
Okay.
So that's why in infants, they sometimes can present a little bit earlier than a year of age, but we typically don't try to scope those patients unless they're really failing to thrive, they're not growing well, or they're refusing all their bottles, and more of that kind of picture. The old patients that we typically see are going to be like the 12 to 15-month-olds who've been started on solids, and now they've had enough exposure to certain foods that they've probably developed some kind of allergic of the EoE in their esophagus at that point. That's led to more nausea, vomiting, and spitting up. But typically we see patients more of a toddler age. And that may also be because we don't love to scope infants at the first go. We're a little bit more cautious about putting a younger child under anesthesia and risks associated with that. And whether we, do we need to be looking for this ethically, we kind of have to really weigh risks and benefits of that as well. So
if a pediatrician, suspected this, you still recommend they refer to a gastroenterologist, and you would make the call whether to scope or not. So
and that typically, like, we don't, I don't meet people and say, hi, nice to meet you, here's your scope. So we're a little bit more of a, let's see what happens. We meet the first time, we see what the trend is, and the trend is not looking good, where their weight curve is flattening, or their, eating and drinking is not getting better. Or if the parents have more significant concerns, like, really felt like they maybe weren't being heard, or, the vomiting really is happening quite a lot, then that would trigger us to want to scope those patients sooner. So
now to clarify for our listeners, the dysphagia or difficulty swallowing, that could be an indication of EoE, but what are some other conditions that it could be associated with?
Absolutely. So that's a wonderful question, because we do see other causes of dysphagia. They're a little bit more rare, I would say, and achalasia is one of them. And that's when you have more of a neuromuscular issue with can be autoimmune. It can be just a disconnect with the swallowing function of the actual esophagus. That is also a diagnosis that often will start with a scope. And then if the scope is normal, then we kind of move to doing a manometry. Or you can do X-ray tests to look for that as well. Other patients will be born with esophageal issues, so tracheoesophageal fistulas or abnormal connections that develop in utero in infants. And those patients are often diagnosed very early on because they have complete intolerance of feeds. And then they have X-ray testing and imaging done, which looks for those abnormal connections. And then they need surgery, and then the surgery leads to dysphagia. In other patients, more severe acid reflux can also lead to dysphagia symptoms. And a lot of times you can get esophagitis at the very bottom of your esophagus just from acid reflux, and then that can lead to the feeling of dysphagia as well.
Let's go back specifically about EoE. Give us a little overview of the prevalence of this and why it's so important that clinicians understand the pathophysiology and the clinical presentation so that they can make this referral sooner to a GI doctor.
So EoE is what we would consider a younger disease compared to the other things that we often see in GI. So it's only really been around for about 20 to 25 years. And the prevalence is increasing over time. And whether that's because it's happening more often versus we're diagnosing it more is kind of still a matter sort of up for debate, but it's certainly happening more and more often than it was in the past. And it's probably because we're a little bit better at diagnosing it. So the prevalence of EoE, when we look at it in patients who are all getting upper endoscopies, is about 4%. When a patient is getting an upper endoscopy specifically for dysphagia, that can range between 12 to 22%. And then in adults, it can be up to 6.5% of adults undergoing endoscopies that have EoE.
Oh,
In terms
wow.
of the overall prevalence, we're seeing case rates of kids in about 5 per 100,000 persons per year, and about 20 per 100,000 persons per year in general in adults. So the prevalence is certainly increasing over time.
So you definitely want, we definitely want our ER docs and our pediatricians to be aware of this.
Absolutely,
Sure.
because we're seeing it more and more often, and it might be because we're looking for it more.
Yeah. Now, just, briefly, what should we know about the pathophysiology of this?
So it's interesting because with time, what happens is after you have this more, what we consider to be in a chronic state, that the esophageal tissue starts off with just swelling and what we see in our scope, which are like little white patches. And you can also see furrows, and occasionally you can see rings that look kind of like round rings in the esophagus, which are the markers of this of the inflammation. The inflammation over time can actually worsen from just being regular swelling or edema and worsen into scar tissue and fibrosis. So the fibrosis is what leads to the esophagus from being like a normal, flexible, kind of distendable tube to being more of a narrowed region that can lead to areas of narrowing strictures and problems with food getting stuck in those areas as well. So over time, as the disease progresses without treatment, you can get more narrowing and more fibrosis and issues with this scar tissue formation. And then that becomes a problem when patients get food stuck, because not only is the food stuck, but there's also a narrowing that needs to be treated with possibly a dilation as well.
Yeah, and this is why I'm glad you brought up this in your slide set, to help providers who are non-GI providers understand the pathophysiology, because that really helps frame the importance of why an earlier diagnosis is key. What I want to do next is I want to focus on your cases. Like, we always love real world examples. And I think these do a great job of really framing in a real world scenario what could be presented to them, to a non-GI provider in the real world. So let's go through your 2 cases here. You have an adolescent patient, a typical adolescent patient that they might see.
Absolutely.
And then you have a younger patient. So this is exciting. So
yeah, so this is like honestly just like a classic case of what we see in the GI clinic. It's a 14-year-old boy, and what happens? So we'll say that this is in the ER. He shows up in the ER, in your ER, at 10 p.m. because he ate a sandwich, and at some point the bite of the sandwich or whatever he was eating, maybe it was like a chicken sandwich from Chick-fil-A or whichever it was, and it got stuck in his throat. And he wakes his mom up and he's like, it's not moving. And this is not the first time this has happened. So his mom is trying to kind of coach him through it, and it's okay. But then she notices that he's not able to swallow his saliva. So he comes to the ER, and then mom mentions to you like, oh yeah, this has happened before. We had to do the Heimlich, and that was what happened a couple of months ago with the chicken. And so then what happens is that patient, you'll call GI, you'll get a scope, and what you will hopefully tell them as an ER doctor is that you should really look out for EoE, and he probably needs follow-up with a gastroenterologist. And this is a very typical patient because it's usually a Caucasian male. And often they've been having symptoms for a while and they've just ignored them, or they've started to just accommodate different foods that work better for their esophagus. And it's the times where, they're either up really late, or they're, at a school function and there's no other alternatives for them. That's kind of when these things happen, where they're out at a restaurant. And those kind of patients are the ones that you'll end up seeing in the ER with a food impaction. And then if you ask a little bit more about their history, mom will say, oh yeah, grandpa used to have to get his throat stretched out, but everyone told him that he was fine and that's normal, and you can just get that done every 3 months. And those kind of cases, you're just like, oh, well, that's not normal. So, and then oftentimes what'll happen too is, they'll come in with their parents or even their dad, and then you're telling them about the history, and the parents are kind of looking at you, they're looking at you, and you're looking at them, and you're saying like, why are you looking at me like so intently? And the parents they will often admit and say like, that is exactly what happens to me, or like my husband complains about this all the time too. And it's like kind of like slowly you sort of get this whole picture of a family history of multiple family members also having the same issues. It doesn't always happen in a genetic pattern, but it often can happen in that path as well. So,
well, that's very interesting case.
Yeah, it is.
Wow. So tell us about the younger patient that you have
so
here.
Oftentimes what we will see in the younger patients is, a toddler, 15 to 18 months, and sometimes older, and occasionally we'll have the 3 to 4 to 5-year-old, and the family reports that they only eat 5 to 7 foods. And I can tell you, I thought this was my toddler too. He's accepting more foods now, but a lot of patients will tell you that they will only eat certain foods. If you don't have those foods, they refuse to eat everything else. Trying new foods is a battle, and meal times are often a battle too. And then they also, you'll notice that the patients, when they have the foods that they will eat, they still aren't growing really well. They're failing to thrive. They have food refusal. They have weight loss. When they're eating, they're kind of holding on to foods in their mouth. They're refusing to swallow at all. And occasionally those things are, improved by speech therapy, or, it seems to be more of a behavioral issue, or potentially they have other sensitivities, or they have more sensitivities to certain textures of foods. Maybe they have some other underlying different disorders like autism spectrum or something like that. But oftentimes the oral aversion, where they're spitting out foods, they feel like things don't taste right, or they don't want to try new things. Those are classic symptoms that you should still refer to GI. And we're not going to scope all of those patients, but if they have, weight flattening, or their weight is sort of kind of evening out and they're not growing and getting taller as they should be, or they're failing to thrive, those kind of patients are the typical toddler type patients that we see.
So the point here is not that they're all going to get scoped, is that the pediatrician or family doctor is going to refer the parent and the patient to a gastroenterologist, and you would make that assessment on the next step. So that's
Absolutely.
The key here.
Mm-hmm.
That's great.
Absolutely.
You have some additional slides that I think are very interesting to show our listeners and our viewers on the esophageal findings. I'm sure folks may be curious to see what you see when you look at the results, when you're doing your endoscopy, and what you're seeing.
Yeah. So what we see, so a typical esophagus is going to look like, the best way to look at it is kind of like on your skin here. You can kind of see the vessels sort of in your tissue. That's what we want it to look like. And you can see in the first photo that you can see those vessels. They're beautiful. They look great. And then if you look at the photo that's beside that picture, you can see that you have very kind of a lumpy, bumpy sort of mucosa. The tissue looks almost like it has rings all the way through. So it looks almost like you're looking into a cave with rings. And also in the other picture, you can see too that they have these kind of linear lines. We call them furrows that kind of go all the way through the esophagus. And the tissue looks much more swollen. And more classic findings, and you can see that in this photo too, are those white specks, or white exudates is what we call them, that sort of scatter throughout the esophagus. And those are actually patches and little pieces of eosinophil islands almost. So those are just collections of eosinophils in the tissue itself.
So is that what, if you're doing an endoscopy, is that what you would take a piece of and
yes,
look under the microscope to confirm? Now, while we're on this slide, how is the diagnosis of EoE made definitively?
Definitively, we do a couple of different things. The biopsy is what is going to tell us exactly what's going on. The biopsies are read by our pathologist, who look at it under the microscope, and they check to see how many eosinophils there are per high-powered field. And if they're greater than 15, then that is a pretty classic diagnosis of eosinophilic esophagitis. So greater than 15 eosinophils per high-powered field under a microscope. We also use other factors to determine whether patients have EoE. One of them is by using an endoscopic reference score. We call that an EREF system, so that evaluates whether the patient from a level of 1 to 2 has any exudates, rings, and if they have edema, which is the swelling, and furrows, and then a stricture, whether they have it, which is a yes or no question. So that tells us as well kind of what endoscopic findings that we see as well. And then during the office visit, we'll ask the patient about their actual symptoms. And the symptoms can include whether they have difficulty swallowing, how many days of dysphagia they have on a weekly basis, and, whether this affects their day-to-day life, how fast their child eats compares to others. And then, we try to ask more specifically about how many times they have the food impaction and how often it's affecting them.
Well, Dr. Patel, this is so helpful. In summary, so we can remind our listeners, what are the top things to remember here from this discussion, what they need to do when they see the patient in the ER or if they see the patient in their office? What
Absolutely.
are your top tips?
So to summarize, if you're seeing a patient in the ER who has a food impaction, it's definitely important to keep eosinophilic esophagitis at the top of your mind. Things to ask would be if this has happened before, and oftentimes it has. And when you're talking to the GI staff, you can certainly say, this may be worth it to evaluate for eosinophilic esophagitis. A lot of times they'll take photos, and some other staff won't take biopsies after a food impaction, but it's still important to get those biopsies so we can get a diagnosis. And then also making sure that those patients end up having some kind of follow-up with a GI referral after that emergency room visit, and hopefully having some continuity of care after that as well. That would be really helpful.
And how about in the doctor's office, in the pediatrician's office?
Yeah, so the pediatrician should definitely look out for in younger kids, issues with recurrent vomiting, failure to thrive, poor growth. And in older patients, asking more directed questions about acid reflux, especially about the burping things up. And then in older patients, asking more specifically about whether food gets stuck in their throat or even other things that they swallow get stuck, because sometimes they won't come out and just tell you that. A lot of times you have to dig a little bit to find that out. The older patients and other patients as well often will also have other allergic histories. So other atopic symptoms like asthma, allergic rhinitis, nasal polyps, and then eczema. All those things should be a red flag to refer to GI, especially if they're having other GI symptoms as well.
Well, this has been phenomenal, and I hope it helps the clinicians who are out there serving our pediatric patients. Thank you so much, and we hope to see you again on another episode.
You're so welcome. It's always lovely talking with you.
Oh, thank you.